bit of what we expect the sort of application process to be like this year. So we're going to cover the recruitment timeline, the major changes for from last year, look at the competition ratios just to put some fire in your belly, go over the MSRA, the interview, self-assessment, which is the portfolio, and then at the end we'll answer whatever questions you guys have. So you can put them in the chat as we go along or just save them until the end. We're not going to talk about the Northern Ireland applications, academic, clinical, fellowship, or the SC3 application. But if you have any specific questions related to those, then you can email us and we'll try to help you separately. So this is the recruitment timeline for this year. You should all be quite well acquainted with this now. We are in the middle of the application period, which closes on the 23rd of November. The MSRA is the next big sort of milestone to look forward to, and that will be from the 4th of January to the 16th of January. The results will come out on the week beginning the 5th of Feb, and then on between the 13th and the 26th of Feb, you'll be able to upload the evidence to support the scores you've given yourself for your self-assessment. During that time, you'll also be invited to interviews, and you'll be able to preference the programs you want to sort of train at between the 26th of February and the 19th of March. The interviews will take place between the 12th of March and the 15th of March, and then for successful applicants or candidates, you'll get your offers on the 26th of March. So there's been a couple of significant changes to this year's application cycle, which is quite refreshing because they've basically kept the same sort of very choreographed process for the last few years, and it was getting a bit boring, and I imagine boring for interviewers as well. So in the last year and the years before, for the last few years, it's been equally weighted in terms of a third of the marks, a third of your ranking coming from the MSRA, a third of your ranking coming from the portfolio, and a third coming from the interview. Whereas this year, the MSRA only counts for 20% of your overall ranking. The portfolio counts for 30%, and they've massively increased the weighting for the interview, which is now 50%. So that's much more important. They've also changed the structure of the interview. So for the last few years, it's been the same 4 sections with the same, with exactly the same questions, even down to the ethical scenarios, which were the same for like 3 years in a row. So they have changed that for this year. We don't know exactly what the interviews are going to be like, but from what they've told us, it's going to be 2 10-minute stations, which is where they're going to be assessing your commitment to specialty and your communication skills. So we're expecting it to be more like the sort of old school interview format. Sure, a lot of you sort of seen data like this. It just shows how the competition for radiology training is going up year on year, and it's like really started spiking in the last few years. So last year, the competition ratio was almost 9-1, which is fairly eye-watering actually. So it'll probably be, the trend will probably continue this year. It's that sort of similar to other hospital sort of specialties, or like close to like ophthalmology nowadays. So yeah, you can expect that trend to continue. So obviously being here and attending talks like this gives you a good opportunity to sort of get ahead of the competition and give yourself the best chance of getting a number. So Jamie's going to go and talk about the MSRA specifically.
Okay, so yeah, moving on to talk about the MSRA now. Even though they have decreased the proportion of your marks that are represented by this as your total score, it's still going to be crucial to your application. They're using it in a similar way. So they start with the long listing process, and from that they have 850 people who are eligible for interview. But then if that number of people who are eligible for interview exceeds the capacity of the interview, then your score from the MSRA will determine your rank for the interviews. So as well as being part of your total score, it's still something that they can determine whether you're going to get an interview or not. So it really is important that you put the effort in to prepare for the exam and that you don't underestimate it. There is a minimum score to be considered eligible, which is 201 in both sections. Sounds quite a high number, but that is a very low score. And as Uzi mentioned, this makes up 20% of your final ranking, where it was previously a third. So the exam itself, then, it's been in the system now for a few years. So they first piloted it in 2016 in radiology, and then they involved it in recruitment properly from every year beyond that. It's a computer-based exam that was originally developed for GP recruitment, and it has become adopted by other training programs as well. You do the exam in a Pearson VUE test centre. So this is the place where you go to do your driver theory test, for example. There's loads of them all over the country, and you get sent a list of where you can go to book. And the exam itself is made up of two components. So you have professional dilemmas, and then you have clinical problem solving. The questions are a mixture of questions that count towards your score, but then they throw in some questions that are what they call pilot questions. So questions that maybe have just been written, and they want to see how they fare in a test population. So out of the 50 questions in the professional dilemma, only 42 of those are actually counted. And then similarly with the clinical problem solving, you'll answer 97, but only 86 of them are counted towards your score. And then each section has a different time allowance. There's no negative marking, so have a go at all of them. And you're not aware which ones are pilot questions. So I guess the ultimate tip here is to don't underestimate it. You think, oh, it's only 20%. There's much bigger chunks of marks to be scored in other things. But like we've already mentioned, the competition ratios are really, really high. So it's important that you do everything that you can to maximize your score in each of the sections as part of the application. And then it could be the difference between getting an interview or not. So it's really important that you give it top effort. And as you can see as well, the score that they've set as the cutoff has kind of gone up over the last 2 years. So potentially it could go up again for this year. So yeah, once again, just make sure that you put the most effort in that you can. It's not like having to open up all the medical textbooks and revise for things as though you're preparing for like MRCP or something like that. It's aimed at more medical school finals kind of level. And then there's different resources that you can use for the professional dilemmas, which I'll move on to. Because your score is kind of taken as a whole, it can be quite useful to know that you've done well on the MSRA when you then go into the interview. And if you think that your interview performance wasn't that great, you'll probably potentially have marks then from the MSRA that you'll be able to use to bolster your entire score. So moving on to look at some of the resources now. The first thing that I want to talk about is the GMC Good Medical Practice Guide. So this is something that's widely available. We'll have a link to the PDF in the references that we send out. And this is the basis for the professional dilemmas section. So if you have an understanding of the content of this, then you'll have an understanding of the type of answers that they're looking for when you do the professional dilemmas. And also, if you go to the GMC website, then they actually have some scenarios that you can work through. These are like worked examples of things that are the types of scenarios that you'll come up against in the exam. And then there's a few guides that you can look at as well. So everyone knows the Oxford handbooks, the clinical specialties and clinical medicine, but they also do a situational judgment test, which once again covers that kind of professional dilemmas style of question. And then there's online resources as well. So between the three of us, we've got experience of using both of these. So MCQ Bank and Past Medicine are both very, very good. We've got a large database of questions covering both of the different styles of question. And then if you also go to our YouTube, then we've got an interview with a candidate who scored 600 on his MSRA. So it's a very thorough interview that Mohammed did with him, talking through everything about his experience with preparing for the exam, what resources he used, what type of questions, all that kind of thing. So you can find that at RadCast Academy on YouTube. So moving on now to look at the interview. So I guess who knows? There's a lot of changes to the interview this year. So we don't really know what to expect. But there are a couple of things that we are aware of that we've already been told. So we know the dates. Invitations will go out on the 20th of February, and then the interviews themselves will happen between the 12th and the 15th of March. And it's booked kind of on a first come, first serve basis. For the previous years where they've run an online interview, they've used Microsoft Teams, but they've done away with that now, and they're using a new platform that isn't something that we've heard of being used in other recruitment rounds in other specialties. And also they've changed the structure of the interview. So previously you had that one 15-minute station that was then subdivided into small sections. But now it's going to be two 10-minute stations, one for commitment to specialty and one for communication skills. So the things that we don't know then, the precise structure of the interview. So you have the two 10-minute stations, but are they further subdivided like they were for the previous interview? Or is it just going to be a case of the interviewer has 10 minutes to ask you about commitment to specialty? We don't know how they're going to do that. It's highly likely, based on the fact that they've gone for this style, that it's going to be more like a classic specialty interview. So questions around why do you want to do radiology, evidence that you've got that backs that up, what is your understanding of radiology as a career, all those sorts of things. And then there'll be with the communication skills, that'll probably be more around like communicating with colleagues, communicating with patients, teamwork, stressful situations, those kind of things. So as soon as we know more information, then we'll be disseminating that via our own platform. And that's also where we'll be announcing our interview slots as well for preparation in the new year. So if you want to hear about that first, then sign up at radcast.co.uk. And I'll hand you over to Mohammed now to talk about portfolio self-assessments.
Okie dokie, let me just share my screen. All right, a few things. Number one, let me go into presenter mode if I can, which I don't think I can for some reason. Is it not? Why is it not letting me? Okay, 2 seconds, guys. All right, there we go. Number one, I just saw these photos with waste time. What is going on here? This is the worst photo of this platform. And by the way, this is the new platform, this Cupacom Recruit, which we have no experience of. We've looked at the website. It looks like it's from 1990s when the internet was first invented. So please have a look, see if you can mess around with the system. It used to be on MS Teams, but now it's gone to this. But this photo needs to get changed, number one. Number two, I look so tired here. Like this, I need to change this image too. Like this can't be publicized on the internet. I need to put like a photo in because I look so tired and I'm so drained. And obviously my hair looks a mess. But moving on to the portfolio self-assessment. This is the thing that between now and the end of your application window, that is like the end of November, you have time to secure as many marks as possible, as we say, to secure the bag as much as you possibly can. Because compared to things like MSRA, where you have no idea what the questions could be, they could ask you about contraception, they could ask you about pediatric immunizations, they could ask you about some next level malignancy. You know clearly what they want from you when it comes to your portfolio. So it's key you do what you can to secure those marks. So when we reviewed it compared to last year's, on the surface, it's pretty much the same, which is really good, because last year it was a huge curveball. So there are some of you who are in the participants for this talk who are reapplying this year. And you know, having gone through it last year, how much of a curveball it was. It threw us off guard, and definitely it threw the candidates off guard. We think this year is where they're going to change up the interview. So that's why it's really important that you secure as many marks from MSRA and also from the portfolio, because it gives you a buffer going into something that is pretty much unknown. When it comes to the self-assessment, it's all done online. You don't need to go to your nearest WH Smith to buy a portfolio. That market and that niche has gone. That business is now dead. Long may it live. But you will be asked to self-score yourself on Oriel when you're applying in November. Then you'll go sit the nonsense that is the MSRA, and provided you meet their cutoff score. And the cutoff score is in two parts. Number one, you've got to get those minimum 201 in one sections. That's basically there to, number one, make sure you're not clinically incompetent. And number two, so ethically weird that you're potentially the next Harold Shipman, all right? That's what they're just saying, like, you got to get this as a baseline so we know you're competent enough to get ranked. Then, as we've said, 850 people will then be invited. Let's be honest, the number of applicants is not going to be 850 or less. If you looked at the numbers that Uzi was saying, it's going to be in the thousands. So they are going to be using the MSRA to shortlist you. So you got to make sure you do what you can to secure those marks. So let's say you've been very good in your MSRA, you watched our videos, you used all the resources Jamie advised, you did all the question banks, you did it religiously, you get shortlisted for an interview. At that point, they'll be like, okay, congratulations, you are now able to upload the evidence to justify why you gave yourself those marks. So let's say you didn't get shortlisted, you will not be asked to upload your portfolio. Nobody is going to look at your portfolio or score your portfolio. You just unfortunately have to reapply in the next application round, okay? So at that point, you'll be asked, okay, you mentioned you did a taster week, where's your letter? You did an audit, give us your evidence, your certificates. You've said you've done teaching, where are your slides? You said you got the prize. You said you got the RadCast anatomy prize, where's the certificates, okay? And of course, any certificates that you need from us, we will of course have sent it to you by this point. So please, if you're waiting on certificates from us, we are working slowly but surely through the backlog. Now, few things you got to be aware of. Some people last year thought, you know what, I'm going to score myself highly, but I think I'm going to get that certificate. And that never materialized. You can't change your score once you've clicked submit on Oriel. You said you've given yourself full marks in domain 1. Well, you've given yourself full marks in domain 1, all right? Now, when they ask you to upload evidence and you don't give the evidence of full marks, they're going to be like, why? Why did you not have this evidence when we told you you need it at the point of submission, okay? Or that you're like pretty much going to get it. Only completed achievements count. This happens a lot with degrees. People say, oh, I'm doing a PG cert. I'm enrolled into a PG cert, but I'm getting my certificate in September 2024. It doesn't matter, because people do, and they have gamed the system where they apply for a degree with no real intention of completing it. They just want to say, I've enrolled. They will say, no, you had to have had your PG cert certificate by the time of your application, okay? So pending things do not count. But there's one caveat to that, which I'll come on to in the research section. Please do not overclaim your achievements. A few candidates last year did get caught out for this, and they had been shortlisted, they had got through the portfolio, and they were just awaiting their interview, and they got an email saying, we have done a review of your portfolio, there has been a discrepancy noted against your portfolio, and now it is being reviewed. That is the last thing you want to read before an interview with panel members that are recruiting for radiology trainees, all right? Because they do take it seriously. Nothing eventually happened to those candidates, thank God, but you don't want that stress. Like, you just don't need it. So please do not overclaim. Like, don't fudge what you think you have and try and be like, oh, I'm going to word it in such a way. They won't take it. They'll just be like, no, 0. All right. And you can claim achievements in multiple domains. This was one of the big things that happened last year. So, for example, you've done an audit, which you've then published. You can put it in both the audit domain and the publication domain. So you can get marks for those as well. And it has to be within the last 10 years. Okay. So what you did back in year 6 as a 10-year-old or 12-year-old will not count. And what your ballerina as a year 7 will not count either. Okay. Either if you did pre-medical, like graduate entry, all the pre-medical stuff will count. The medical school stuff will count, foundation training, and then a few years if you've like taken F3 years or like clinical fellow roles. So there's 7 portfolio domains, and now I'm just going to go through one by one, outlining the big things that we noticed and some opportunities for you to kind of secure those final golden low-hanging fruit to like boost your portfolio in the next couple of weeks. Okay, because we know it's like less than two weeks now before you have to submit your application. So the first domain, the commitment specialty. Now, the first thing is taster weeks are still there. Like, you have to have done a taster week. That's one of the bread and butter things about the commitment specialty domain. You can't really get away from that. The taster weeks that you do can't be you doing the same thing twice. For example, you sitting in with Uzi as a consultant head and neck radiologist in week 1, then in week 2 turning up again saying, hi, Uzi, I'm back. Because number one, Uzi be like, well, what the hell? Why are you going to watch me do the same head and neck reporting all over again? And number 2, from the interviewer's perspective and the application panel's perspective, they want to make sure that you've seen as much of radiology as possible. So not that you are just looking at pediatric radiology without understanding that there's a whole world called IR, or image-guided surgery, if you want to be fancy, but that you understand the specialty as a whole. So please do not do the same taster week twice. It's not about numbers. It's about value. 3 days minimum, whole day equivalent. So if you do half a day on Monday, that's half of the 3 days. Okay, so you need to do another half a session to get 1 full day, and then so forth. Okay, last year there was a huge problem which caused a lot of issues in departments where people were turning up to do the same thing multiple times, and everyone's like, what's going on? This is a bit stupid. So they've changed the way you can show commitment. Number 1, courses are back. They were out of fashion last year, but they're now back in fashion, and it has to be a day in length minimum in terms of hours. Secondly, you can kind of like mix and match your experiences. So for example, you're in a hospital which aren't very nice and won't give you the time away to do a full taster week. You can be like, can I go to the MDT and sit in with the consultant, and I'll kind of just shuffle my chair next to the radiologist and ask the radiologist what they're doing. Then I'll get evidence from that radiologist saying that I was there, I asked questions, I got involved, I was curious about the imaging. That can add up. Okay, so you can mix and match, and you can work your way to get these different commitment to specialty type of elements. One thing I always tell candidates is, please have a very long, hard look and reflect on what you did at medical school. Majority of medical schools still do not have a core radiology component, but you may realize, wait a minute, that special study module that I did with the orthopedic surgeons, I kind of did sit in with the radiologist. Could I get evidence of this? Number 2, breast surgeons, for example, they do these symptomatic and screening clinics. There is a breast radiologist there. Can you reflect on that, and can you get evidence of that? So reflect on what you've done. I'm sure you do have these things, but if you don't, you need to get a taster week. One thing we get asked about time and time again, I am not in the UK. I am an international medical graduate, and I'm applying directly from my home country. That's fine, no problems. You're allowed to do that. Will my non-UK taster week count? The answer is no. And you've got to ask yourself why. And it makes a lot of sense. the training and the way UK consultants work in radiology is very different to how consultants work abroad. You are not entering radiology training to then reflect the way they are trained abroad. You're going to do UK training. So they want to know or to see that you understand how UK trainees are trained in radiology and how UK radiology consultants work, because that for them shows that you are aware of what you're getting in store for when it comes to FRCR exams, what you'll be expected to do on call, what you'll be expected to do during the day, etc., etc. So please, if you are abroad, don't necessarily think that your taster week will count. It probably won't. So you need to go and get other exposures through the other ways that they've mentioned in the portfolio. Domain 2, leadership and management. This is the one that really took the mick, both last year and once again this year. It hasn't changed. The wording is exactly the same from this year and last year. But this is one of the most difficult parts of the portfolio to score anything in. Like, seriously, like, even if you're getting 2 points in this, this is very good. All right. Of course, if you're scoring 7, you're either the RCR president applying to radiology, which is a bit weird, or you've been very fortunate in the sense that you either prepared very early on, which was a very good strategy, or you just found yourself in the right place at the right time. But majority of candidates will often score 2 in this domain, all right? Because they can only get a local level type of position. Not everyone is going to be on national committees or even regional committees, okay? So please don't beat yourself up about this. In terms of being effective with your time, I would not be like sweating blood and tears about getting marks in this. I'd be like, it is what it is. I can make up these marks in the MSRA, and I can definitely get myself slicker interviews to make up my potential lost 7 marks. All right. So please don't beat yourself up about this. Some of you in the participants are applicants for future years. So you're thinking ahead of the curve. Fantastic. And you want to be like, okay, so what can I do to get these marks? So a few things. Our friends and colleagues at IR Juniors, an amazing group of individuals promoting IR as a specialty. They often recruit for positions. And if you are interested, if you are committed, and you want to do the work, of course, please don't just do these things for portfolio. Also try and give back to the community that you're serving. Go to IR Juniors, see if they have any vacancies and help out and be like their social media rep. Maybe they have other positions that we aren't aware of, and get involved. And then, of course, you have to do it for 6 months to get any meaningful points on your application, but then get those certificates. If you want something that's a bit easier and a bit more local, think of things like hospital mess president, the lead, the foundation doctor lead, help them organize their teaching, help organize rotas, find your nearest medical school and ask the undergraduate radiology society or any society, as a matter of fact, can I help out? Can I be that link between postgraduate and undergraduates and try and help you get speakers for your talks? That would be very beneficial to both you in terms of your application, but also to the medical students who really do value this type of relevant and focused teaching. And of course, non-clinical stuff does count, all right? I know it's not explicitly worded in the portfolio, but it does count. So for example, if you were the volunteering lead, if you were in the chess team, like some of you may have been, I won't say anything about what personality you may have, but if you were in the chess team as the chess captain or whatever fancy, wonderful thing, maybe you're president of the anime society. Once again, I won't comment. I am a diehard Naruto fan, but that does count, all right? You just need to get evidence of it, all right? You can't just put in a photo of you dressed up as like Naruto and be like, yes, please give me 3 marks. They'd be like, what's going on? But if you get a letter saying, okay, you did this, you organized these events, this was the impact, it was for 6 months, then it will count, okay? So it's all about evidence for all these domains, and must be for 6 months, okay? Not 6 minutes, like I was about to say, 6 months, all right? Don't just turn up one day and be like, yes, I want to be part of this society, and then you never be seen again. They'll be like, that doesn't count. And must state your responsibilities and what your role was. And please include your name. Like, you may be thinking, of course, RadCast, I'm going to include. You'll be surprised, all right? In the heat of the moment, You get a letter that's been sent to you. So the person sending it presumes it's for you. It doesn't have your name in it. So when the person marking your portfolio looks at it, they're like, well, who is this letter for? It must have your name on it. Teaching and training, no changes in terms of wording. And in terms of how I would prioritize your portfolio, this is like number one of I can do this in the next couple of weeks in terms of trying to organize something. Of course, if you're planning for applications in future years, you've got plenty of time. So you should be definitely getting full marks in this, all right? And it's all about getting either local level teaching, regional teaching, and of course, international teaching. And this definition of a major contribution, and that as per the portfolio is defined as 2 like teaching sessions that you have led on. So once again, a very easy domain that you should be all trying to get as many marks as possible, minimum 2. Like all of you should not be getting, like nobody should be getting 0 on this in our opinion. Similarly, the formal teaching qualifications, you must have the degree in hand. Intercalated degrees, for example, if you did an intercalated master's in medical education, this will not count. And when we say intercalated, what we basically mean is that during your undergraduate medical training, you decided to take a year out to go pursue another degree. This is a very common thing in UK medical schools. For example, I did an intercalated master's in research. My master's, if I was applying today, would not count, all right? Because I did it during my undergraduate training. This isn't radiology just being meanies, because number one, we are not meanies. We are quite nice. And of course, you can see my room is quite bright. I'm not sat in the dark like an ogre. But it's because last year, the people who oversee all of recruitment for neurosurgery all the way up to like general practice, they said to make it more fair, whatever definition of fair you want to use, we will not get into that. We will remove additional points for intercalated degrees. So there's not just in radiology, it's in ophthalmology, psychiatry, any specialty application that has a portfolio component, they do not have points for additional intercalated degrees. Your prior medical degree, for example, if you are a graduate entry, will count, which I'll get onto, okay? So one thing they did add to this was this, you can get recognition for being a fellow of the Higher Education Academy. Now, most people become a fellow through doing a PG cert like I did, all right? But some candidates become a fellow by accumulating a portfolio of work, which is fair because that does take a lot of time. But last year, they would not have got recognition for it because they don't have a degree attached to it. This year they do. We think that was fair. And of course, med ed courses do get in touch. So if you're struggling and you're like, I just want to get 2 points, then as you can see, you need to do training and teaching for at least 2 days. One thing we get asked about is, oh, I have done X course that had some teaching in it. The core program must be teaching orientated, all right? It can't be like, oh, I went on a course to teach me how to do a lumbar puncture, and one of the lectures was about how to teach. That won't cut it. The core course has to be about teaching and training and how to be an effective teacher, okay? Don't try to fudge it here. The examiners, the assessors for your portfolio do not spend their time, which by the way, they're doing it for free on their own study type of thing. They're doing out of the good nature of their hearts. They won't take the time to Google your course. That's not their job. You're meant to provide enough evidence for them to be like, yes, I agree, or no, I disagree. They're not going to start ringing up the course provider, but actually, can you tell me what this person did? They don't have time. There's so many applicants that they just don't have this luxury, okay? Moving on to audit and quality improvement, no changes, which is great because this is number 2 of I need to make sure I get full marks in this. If you're not getting full marks in the audit and quality improvement, you've really let yourself down. Like there's no reason why you can't get full marks in this domain. Like everything is there for you. RCR with their amazing platform of Audit Live have told you, here are the templates, please go and do, all right? And if you want to be strategic, go pick an audit with a more trauma focus, an acute focus, and go do it. For example, Ottawa knee rules are people doing x-rays based upon a standard guidelines. That won't take you long at all. And with the fact that all records are electronic, you really don't have an excuse. Some of you may say, well, Mohammed, Uzi, Jamie, I'm not based in the UK. We don't really do guideline-driven medicine, especially not relevant to NICE or to the RCR. What do I do? How do I do an audit or a quality improvement project? Use guidelines from other countries. So for example, you want to use the American Heart Association guidelines, that's fine. You want to use NICE guidelines, that's fine. You can take those templates and do it in your home country. Doesn't matter. They want to see that you understand the audit and quality improvement cycle and how to do it, okay? So in terms of audit, to get top marks, you need to complete the cycle. What does that mean? We've already had a few questions, which I want to clarify. When we say complete the cycle, in the first part of the cycle, you find out that whether your department is meeting or not meeting the guidelines. You then, as part of the initial half cycle, tell the results to the department and say, this is how we can improve it. That's all good. But now, to see if you had any impact, you need to complete the cycle. So you basically re-audit or redo the quality improvement cycle to be like, actually, my teaching on Ottawa knee rules has helped improve the guidelines being adopted by the department, okay? It has to be radiology related. Like, come on, it is a radiology application. You got to show indirectly commitment by making it all radiology related. And honestly, like, I think most audits, the way imaging is so critical to basically a patient breathing now in a hospital, most audits are imaging related indirectly. As long as it has some component of imaging, you're good to go. And you got to have done 2, all right? And of course, present them, and you can like get them presented at conferences, publish them if you want to. So it's a good stepping stone into the other domains. Moving on to the research domain. Once again, no points for intercalated degrees. It's not just radiology, it's across all specialties, so don't take it to heart. That like, oh, damn these radiologists. It's not just us as a specialty. The big thing, which you should all be aware of, is letter to editors and these case reports. Traditionally, this was the stepping stone into the academic world. For a lot of doctors and medical students, they're like, how do I start my academic career? I'll start with a letter to the editor, get my feet wet, move on to a case report, and slowly and gradually you build yourself up to be the next professor and start doing meta-analyses and getting your names plastered all over the academic world and getting invited to all these conferences. And of course, because there's no money in academia, you still have to fly economy. But letter to editors and case reports have now been thrown out. They fell into the puddle. They're all wet and being told, no, you're not worthy anymore of 4 out of 5 marks, all right? You're a lowly 1. We think it's a real shame. We shed a tear. But that's just the nature of the game you're playing, all right? So when it says for 4 out of 5 marks, at least 1 peer-reviewed publication relating to radiology as a first author, this cannot mean letters or case reports, all right? It has to be, for example, a systematic review, a randomized controlled trial, a retrospective analysis, okay? Meta-analysis, whatever, but not case reports or letters, all right? Similarly, people often get confused saying, oh, Mohammed, I've sent something to peer review. Does that count? No, all right? When things are accepted, they say it has to be accepted in press. What that means is basically that you've sent it to the journal of your interest, like, for example, ClinRad. ClinRad have read your paper and be like, this is amazing. This is going to revolutionize all of medicine. We will accept it, but because we've got a backlog of other editions, it's not going to come out anytime soon, maybe in September 2024. That's what we call accepted and in press, all right? That does get the marks, all right? But not just sending it to peer review does, because the peer reviewers could be really mean and be like, no, this is crap. Like, well, why have you even written this, all right? We've rejected it. So just sending it for peer review does not count. It has to be accepted, but pending publication. Prizes and awards, no changes. unfortunately, you've missed the boat for our Radiology Anatomy Prize, which got the candidate full marks in this domain last year. We do still have our crack prize open. The deadline is very soon. It's on our website for the crack course. But our crack prize is a national prize, well, kind of international, if we just want to, brush the dust off our shoulders, but it does count. And we're giving 2 prizes for the best radiology reflection and audit. In terms of what else will count, this is, and I may be sounding mean, and I don't mean to sound mean, I promise. We are nice. Being like, please don't think getting like, oh, I got runner up will count. It does. The word runner up means you're not first, right? Like like I said, I'm not taking away from your achievements. I'm not saying it's not worthy of recognition, but I'm saying for the purpose of application, it's not first. And they're looking for first prize. It could be in a clinical context. For example, you were the #1 in an essay. You got the top marks in the anatomy competition. You got top marks in this, top marks in that. For example, the BSIR essay, you may have won that. You may have won the SRT, another fantastic organization's essay prize. That's cool. That all counts. But don't be like, oh, I was runner up in the essay prize. Well, that doesn't mean you won. It means you were not #1, so it doesn't count. Secondly, distinction award of final year primary medical qualification. Once again, people get confused by this, so let me try and clarify. Let's say you got top marks in the surgical component of your year 2 paper. Do you qualify for 6 marks? No, you don't. It's not about individual components of your medical school training. It's, did you graduate overall with a distinction, an honors, or whatever terminology your university used? If you're unsure, ask your medical school. Be like, yo, was I good enough for a distinction? Like, yeah, hell yeah, you were the best person we've ever had. Like, okay, can you get that for me in writing that I graduated with honors or with distinction or whatever title that they claim that you are entitled to, all right? But also, please be aware that clinical stuff will count too. So let's say, for example, you got a top prize in your sporting activity or your leisure activity, whatever it is, that does count too, all right? So please don't be like, man, I was too busy being the world's best beatboxer and I got so many trophies for that, but obviously I'm not cut out to be a radiologist. #1, you are. And #2, please bring your beatboxing skills to radiology, and those prizes will count as well, all right? And if you are going to claim for the final year medical school equivalent, you need to get it in writing, okay? You can't just scribble on your degree honors and be like, yeah, they'll accept it. It needs to come from your medical school saying, yes, candidate did get honors, and we have given it as part of their final degree. Talking about the IR pathway, this always causes people to start like really sweating and like having long sleepless nights about, okay, do I want to be an interventional radiologist? Do I even want to be a radiologist? Like, what's going on? You don't need to really sweat about this, all right? All they are asking you is, okay, we know that there is a growing trend of people applying to radiology who have their eyes set on IR. To help us plan if we can help all these budding candidates become the future consultant IR radiologist, please can you just tell us a bit early on so we can make sure there's space? That's all they're basically saying, because what they don't want to do is come to a point where they haven't appropriately planned. That isn't to say that you come into radiology, realize that you want to be an interventional radiologist, and then you get told, here's the exit. You never applied an ST1, so now you are cursed forever to look at lung nodules. That's not what they're saying, okay? And I'm sure with the workforce shortage, which is not going away anytime soon, that they're going to be like, please, and grab you by the collar and be like, get scrubbed in. Let's start teaching you all our fancy techniques. Similarly, you may have embraced the darkness as a radiologist and be like, I never want to see a living person ever again. I just want to look at my dual monitors or triple monitors or quadruple monitors. The sky's the limit here. And I just want to sit in Dubai like Jamie is and earn as much as I can for the rest of my life. And once again, The RCR president is not going to come and find you in the middle of the night and break your door in and be like, hey, you said you wanted to be an interventionist. Now you're bound by contract and by blood to this specialty training. They'll just say, okay, cool. What do you want to do? That's it. Conversation over. It's just to help with planning. So if you know you want to do IR, then just put it down in your ranking. No biggie. If you're not sure, don't stress. As soon as you find out what you want to do, let your TPD, let your head of school know, and they'll probably help you maneuver into that pathway. Now, final words on maximizing your application, kind of like us giving you that little pep talk that some people on YouTube get like paid millions of dollars for, but we don't, unfortunately. When it comes to this application, at this point, you're either in two camps. You're either thinking super early, which is fantastic, and you've got enough time to be really focusing on your portfolio, because that is all you should be doing. The majority of you will be in the second camp, which is I have 2 weeks before I click submit on Oriole, and then I now have to face the MSRA gods. If you're in that second camp, which the majority of you probably are, you need to be very strategic, all right? Look at that portfolio and be like, okay, leadership and management done. I can't do anything. Just throw it to the side. All right, but this audit, listen, let me go quickly see what's happening in A&E. Can I do a CT head audit? Are they being done in 1 hour? Probably not, because we're busy, but let me just get it on paper that we're not, all right? No problem. Go do it, get it done, and get it presented. Completing a full cycle audit really is not the end of the world, and seriously, just requires a week or two of dedication to get it done. You're not gonna get a meta-analysis published in the next couple of weeks, so don't even bother. You've got the crack prize, which is available, so please do check it out on our website. And then other things, like if you haven't done enough to get 10 marks in the commitment specialty, what are you doing? All right, go sit in the MDTs. The fact that it's getting so competitive, you really need to go the extra mile to get those points. Because once you're done with the portfolio, you take a step back and you open your books. Oxford Handbook of Specialties of General Medicine. You go find Kumar and Clark that you've probably put as a doorstop. You go find these books and you start reading, because you want to give your MSRA your best shot. Don't leave anything to chance. Don't leave anything at the door. And as they say, if you fail to prepare, you will prepare to fail, okay? So it's all about how much time you can invest in, because once you're in to the cool gang that is radiology, you're done. You have your FRCR exams, but that's a different kettle of fish. You're now on a training program. You're now set for your training program, and the world's your oyster at that stage, all right? If you want support, please just get in touch. hello@radcast.co.uk. We are working through your emails. I appreciate we have been slower than normal, but we are getting through. We are not ignoring you. We do take this responsibility that you give us very seriously. We know this means a lot to you guys, and we do try our best to cater to as many of you as much as we can. We are a small team, but we love doing what we do, right? Because we were all there at one stage, and we remember our time doing this, all right? I know I'm getting like emotional now. I'll probably start crying, but just email us. We'll help as much as we can, and we are getting through the emails, especially the backlog. We are getting through it,